send it all to you. Okay, what else was there? Something else has come up. Somebody wants to know topics they should focus. Well, this is the second exercise we are having on topics which you should focus on. See, the aim is to develop safe doctors. It is not having doctors who know the answer to a few SAQs. So it will be against my philosophy if I say you learn this topic and don't learn that topic. Okay. So you'll not be a safe doctor if we teach you to cut corners. So the idea is to learn everything which is goes into making a safe doctor. So if you ask me on the lines on those, I will answer you at all times. But to cut corners, I am not one of those. So please don't ask that to me again. Okay. Surgical steps. Now, surgical steps which are asked are usually only related to the common surgeries which you may have seen in HSA or in HSB. And so they mainly relate to either herniorrhaphy, hernioplasty, thyroidectomy, cholecystectomy, mastectomy. But that's it, and not in great detail as long as you know what is done and you know what is not done. Okay. So in like in axillary dissection, we remove level 1 and level 2 nodes, and we safeguard the nerves. That is the nerve to serratus anterior, nerve to thoracodorsal are preserved, and we don't remove the apical nodes. We don't remove the internal mammary nodes. We don't remove the supraclavicular nodes. So that is the basic idea, and it is nothing very more complicated than that. Then, of course, the standard steps in the rest of the laparotomies, we have discussed it so many times regarding what is done in right hemicolectomy, left hemicolectomy, and we'll cover colon in a little while, so don't worry on that. More than this, what? Breast and thyroid. So, see if you're not satisfied with what I have shared, then maybe we can have some other sessions. But first, you have to understand, because if you know the how we prepare slides is always to talk on it. It is not that these are like your notes for the exam, because then the connections you don't know. What I'm saying now, it will not be, it's not reflected in the slide. So, so the slides are prepared only in connection with the talk. So if you attend this talk, then these slides will have meaning. So I can share these slides with you. So whichever talk you attend of mine, I can share those slides with you, and then they become relevant. Otherwise, they become disconnected slides, and they get keep getting misunderstood and misrepresented. Okay, so just stick to this. I think there is enough material here for you to learn. So both colon and breast we will be covering shortly. So see if you need anything more after this. Okay, so coming now, starting with colorectal cancer. So you know that colorectal cancers, they all start from an adenoma. So that the usual process is there, that initially there will be some hyperplasia of the colonic mucosa, an adenoma will form, and eventually it will turn malignant. And all these intestinal polyps, initially they are just protrusion of the mucosa, and they may be of various types. They may be pseudopolyps, which we see in inflammatory diseases, then hematomatous polyps, which we see in Peutz-Jeghers, and juvenile polyps, then serrated polyps like hypoplastic, sessile serrated lesion dysplasia. Now in this, there is a little change. Earlier, the serrated polyps were considered totally benign, not likely to turn malignant. But now we know that there is a second pathway. One is this adenoma carcinoma sequence, and the other is this serrated polyp pathway. So, serrated polyps, which are sessile depressed lesions, even they can turn malignant. So the risk of malignancy is highest in the villous adenoma. So tubular, tubulovillus, villus. So they are these frond-like tumors. So when they have those kind of an appearance, then they are most likely to be malignant. And if it does not have a stalk, if it is going into the wall of the intestine, and if they are of large size, then they are more likely to turn malignant. Then this is from your clinical practice guidelines, the risk categories for colorectal cancer based on family history. So if there is no family history of colorectal cancer, patient is more than 50 years, then he is at average risk for colonic malignancy. And for him, the screening protocol we recommend is an IFOBT, which is to be done yearly. In category 2 or moderate risk are those who have a family history of colorectal cancer. And in category 3 are those with a family history and the index patient or the index family member whom we are referring to develop malignancy at less than 50 years of age. So then those patients are high risk. There is more chance of this being carried in the families. And also if we know that they are belonging to a family which has got the FAP gene, mutated FAP gene or hereditary non-polyposis colorectal cancer, Peutz-Jeghers syndrome. So they are at high risk. Now be careful because in HSB, especially around HSB, we've got several families who are FAP carriers, mutated FAP gene carriers, and they then are all several members of the family are under treatment for colorectal cancer. Then when TNM staging, I told you in the stomach, similar here, when it involves submucosa T1, muscularis T2, involvement of subserosa T3, serosa or adjacent organs T4. Then we need to sample at least 12 nodes for adequate sampling. Now that is a very important aspect, that the principle behind surgery for malignancy is removal of the tumor and doing an adequate regional lymphadenectomy. It is because of this, whenever there is a lesion in the cecum ascending colon, we have to go high up in the ileocholic artery and ligate it at its origin so that we get an adequate number of regional nodes which are removed. And to do that, once we are tying it so high up, then the blood supply of the terminal ileum, ascending colon, right third of the transverse colon gets interrupted. And that is why right hemicolectomy includes removal of the terminal ileum, cecum, ascending colon, and right third of the transverse colon. It is because of this need to remove not only the tumor but also the regional lymph node. Now, in FAP also sometimes questions are asked, but here in FAP, the main problem is that the disease, the APC gene is actually a tumor protector gene. It protects against the formation of polyps. But in case it is mutated or defective, then the colonic mucosa is free to produce multiple polyps. And over hundreds of polyps are produced in the colon, and these patients are at risk 100% in their lifetime. They are going to develop colorectal malignancy. So if not today, tomorrow, definitely in one of the years, in the subsequent years, the patient is going to develop. And these polyps start coming up at a very early age, 15 years. So we were so sad to see one army officer, means he's gone through his military training, become a major, and had presented with bleeding PR, and he was from a family which was an FAP carrier. So he could have been detected, put under surveillance at a much earlier age, and had prophylactic surgery at a much earlier age. So we must remember that when we encounter family members of FAP, then we must recommend screening colonoscopy at 15 years of, below 15 years, that is at 12 to 14 years of age, because by 15 they will start producing polyps. Now, among the options, when we say prophylactic surgery, the surgery to prevent the development of malignancy in these patients is a removal of the entire colon. And once we remove the entire colon, we cannot directly anastomose the ileum to the anal canal, because then there will be no sphincteric function left. So if we remove the entire rectum. So usually whenever we are doing one of these restorative procedures, we are leaving a small rim of rectum behind. So it's either an iliorectal anastomosis, or even when we say ilioanal anastomosis, a small amount of rectum is left behind just for this continence purposes. So that bit always remains under surveillance. So yearly scopy is done to check if any polyps are appearing there, and in case they appear, then we resect it. Then we have the hereditary non-polyposis colorectal cancer. So here also there is an increased risk of colorectal cancer, and we need to follow the similar principle to check for the development of polyps and development of cancer in these patients. Now, the operations which we have talked of, the right hemicolectomy, once the ileocholic artery is divided at its origin, the terminal ileum blood supply gets removed, and therefore we end up removing the terminal ileum, cecum, ascending colon, right third of the transverse colon. Similarly, on the left side, the inferior mesenteric artery is ligated, so all this area needs to be removed in a left hemicolectomy. In a transverse colon lesion. Now, in a transverse colon lesion, if you see the blood supply, usually the middle colic is also taking off in association with the ileocholic artery. So, if we are ligating the um, uh, blood supply to the transverse colon at its origin, it usually also takes up the we have to ligate the ileocholic artery, and then it ends up as an extended right hemicolectomy, that is terminal ileum, cecum, ascending colon, and the entire transverse colon. So for transverse colon lesions, we do an extended right hemicolectomy. For right colonic lesions, right hemicolectomy. For left colonic lesions, left hemicolectomy. Now coming to the rectum, so rectum is the area where most of the colorectal malignancies take place. And so here, if the growth is more than 5 centimeter from the anal verge, so that means when we do the perrectal examination or colonoscopy, when we measure where the cancer is starting, that distance is more than 5 centimeter. So if it is at 6 centimeters, then 2 centimeters beyond if we cut, so we will come up to 4 centimeters, and still we'll have sphincteric action, and we can do a colorectal anastomosis. Now, in case the growth is less than 5 centimeter from the anal verge, that is, you put your finger and at 1 centimeter, 2 centimeter, even 4 or even 5, if we encounter, then if we cut 2 centimeters beyond, we will be sacrificing the internal sphincter of the rectum. And once that sphincter is gone, there will be no control. So if it is low down, of course, no choice. But even at growths at 4 and 5 centimeters, there is a problem, and this sphincteric control can be lost. So there we prefer to do an abdominoperineal resection, remove the entire rectum and anal canal. So that is an abdominoperineal resection. Now, sometimes growths in the rectum may perforate, or in case of diverticulitis, if there is perforation, pelvic peritonitis, then this complicated anastomosis cannot be made here, and even if made, it may leak. So, in that situation, we do a Hartmann's procedure. So, Hartmann's procedure means removal of the disease segment of the colon or rectum. So, disease colon or rectum is removed, the proximal part is brought out as an end colostomy, and distal part is closed. That is Hartmann's procedure. So it may be reversible in case we are dealing with a benign condition, and sometimes when we are dealing with advanced malignancy which has perforated, and in those situations this may be the permanent solution. So in either case, in Hartmann's procedure, the disease segment of the colon is removed, proximal end is brought out as a colostomy, distal end is closed. Then these as short cases we will encounter sometimes, that is patients with a stoma. So if a patient has got a stoma, It may be an end stoma, a loop stoma, or a double barrel stoma. So, how to make out when we look at the shape? The end stomas are usually circular in shape and have got only a single opening. The loop stomas look a little oval in shape and will have two openings. One may be discharging the intestinal contents, other will be discharging clear mucus contents only. And sometimes we have a double barrel stoma in which both the ends like this but separated out so that there is a skin bridge in between. So whatever situation we see, we should be able to describe it. Next thing is to identify the location where it is. So because based on the location also we get an idea. First we get an idea from the output. If feces is coming out, it is a colostomy. If liquid intestinal contents are coming out, most likely it is an ileostomy. Of course, in the initial stage of intestinal obstruction, there may be a little misunderstanding on the contents because it depends on how far up the feces has gone in the terminal ileum, so it may continue to come for some time. So that initially period it may be a little confusing, but in most situations when the stoma has matured, if it is discharging feces, it is a colostomy. If it is discharging liquid intestinal contents which are bile stained, it is a ileostomy. Then depending on the position on the abdomen where it is, we know that the loop part of the colon or the colon which has got a mesentery is in the left iliac fossa or in the epigastric or right upper quadrant. So if the stoma, this loop stoma is in the right upper quadrant or in the left lower quadrant, then it is likely to be either a sigmoid colon which has been brought out as a loop colostomy or a transverse colon which has been brought out as a loop colostomy. If the loop is in the right iliac fossa, then in the right iliac fossa, the part of the intestine with the longest mesentery is the terminal ileum. So it's likely to be a ileostomy. So those are the broad guidelines on how we distinguish what kind of a stoma is where. Then once we have identified, then we look at what are the complications which are possible. So in the early part when intestinal obstruction is relieved, so like we get in kidney obstructions are relieved, patient has a large diuresis. So similarly here patient can have a large output from the stoma and can get dehydrated. Then in case the blood supply is compromised, it can get necrotic. The stoma can retract under the skin. It can stop producing enough if the obstruction recurs. And of course, the complications related to anesthesia, that the atelectasis, urinary tract infection, wound infection, DVT, and the drugs which the patient has been given that can cause anaphylactic reaction or other complications. Then the late complications in stoma, which we see that the skin may break down. So the mucocutaneous junction breaks down. Then you can have a stomal prolapse. Then the intestinal obstruction may recur. There can be a parastomal hernia. So how will we know hernia? We know that it is reducible when patient lies down, the bulge reduces. When patient stands up, bulge increases, and there is an expansile impulse on coughing. Then parastomal skin issues, and of course stenosis in case the skin around the stoma starts contracting. Then coming to breast cancer. Now, in the routine inspection, palpation, all that we know in breast cancer, we know how to look for what will make this tumor a T4 lesion. Then, how do we stage? So, staging, we remember these two figures 2 centimeter and 5 centimeter, and both these figures belong to T1. So if the tumor size is 2 centimeters or less, then it is T1. If the tumor is more than 2 cm but not more than 5 cm, it is T2. If it is more than 5 cm, it is T3. And if it has got extension to the chest wall, that is to the ribs or intercostal muscles, then it is T4. If it has caused ulceration or a nodule on the skin, it is T4. And if it has created this port-orange appearance, it is T4. And the fourth category is inflammatory carcinoma of the breast. So please remember, in inflammatory carcinoma, it is not infection. It is only an appearance like infection, that there is erythema and port-orange involving more than one third of the skin over the breast, and additionally history of present illness is less than 6 months. Then okay, now for the N category, N1 means that the nodes are movable and ipsilateral level 1 and level 2. So they are movable and discrete, they are separate. Whereas in N2, the level 1 and level 2 ipsilateral node, they are fixed to each other. And there can be no internal mammary node involvement. So only axillary node involvement, and they are matted together or fixed, and they are belong to level 1 and level 2. For N3, it is level 3 nodes, that is apical nodes or supraclavicular nodes, or a combination of internal mammary and axillary nodes. And M0 and M1, metastasis or no metastasis. Then we have this category based on immunohistochemistry, which tells us the pattern of cells and how they are going to behave. So we know the luminal A, luminal B, HER2 enriched and triple negative. Now in this, luminal A has got the best prognosis, triple negative has got the worst prognosis. That is a CR, negative and HER2 negative. HER2 enriched has only got HER2 positivity, no ER/PR. In luminal B, it has got ER/PR positive, additionally may have HER2 enrichment, but the main factor here is that the cells are multiplying at a rapid rate. So if you can see in the slides, then nuclear division is much more, that is why the cells are looking blacker in color. So there is rapid multiplication. We have another tumor marker for this, that is the Ki67 positivity. Now coming to, once we have got the clinical stage grouping done, then we have to plan the treatment. So I've written the plan in both formats for those who are comfortable reading and those who are comfortable following the algorithms. Now it is easier to explain from the algorithm, and this is a direct copy from the Clinical Practice Guidelines Malaysia, the QRCPG 8 pages which I keep talking about. So these 8 pages, this I can't read. Ah, yes. So somebody is asking about BIRADS grading. So we are very, that is again something very colloquial that we talk of BIRADS grading. BIRADS grading is a mammographic grading given by the radiologist. Now it looks complicated to talk about. For us, the main thing is TNM staging. BIRADS is before the diagnosis. BIRADS is before the diagnosis. So we have not yet diagnosed cancer, and we are looking at an image and trying to understand whether there is likelihood of malignancy. So this BIRADS grading is done by the radiologist. Now 0 to 6 looks very complicated again, but from year 3 onwards I have been stressing it's actually quite simple if you separate it into its ends. That 0 is the radiologist wants another image. He is not happy with the imaging. 6 is when the diagnosis is already done. Patient has had a core cut biopsy done earlier and is going for mammography for some other assessment prior to breast conservation or whatever. So in 0, he is not happy with the mammogram, wants it repeated. In 6, he's already got a diagnosis and his opinion does not matter. It patient is already diagnosed to have breast cancer. So 0 and 6 are out. Now we are left with 1 to 5. Now, out of this, 1 is when the mammogram is totally clear, no pathology is seen. So, 1 is also out. So, now you are left with 2, 3, 4, and 5. So, 4 and 5 are suspicious of malignancy, 2 and 3 are pointing towards a benign disease. So, 2 is definitely benign, 3 is most probably benign. Then between 4 and 5, when we are choosing, 4 is likely to suspicious of malignancy, and 5 is highly suspicious of malignancy. So clear 0 to 6, or still any doubts? So BIRADS is basically a radiologist's opinion suggesting the possibility of malignancy. For us, we know triple test, every case with a breast complaint will have a core cut needle biopsy. Still doubt? Is it clear or not? BIRADS grading done by the radiologist before diagnosis of breast cancer. Once breast cancer is diagnosed, then we follow the TNM grading to decide whether it's early breast cancer, locally advanced breast cancer, or metastatic breast cancer. Then, based on that, we plan our treatment. Is that clear? Because then only we can proceed further. Yes? So treatment is not based on BIRADS. BIRADS is just one of the inputs before the biopsy report is received. And once biopsy report is received, then we do the immunohistochemistry, we get the molecular subtype, and then based on the TNM and the molecular subtyping, we are ready to plan our treatment. And then now we are coming to the treatment. Yes, Haranya, still doubt or
Yeah,
asked and
clear
one
up.
away.
I yeah,
Hello?
it's clear up there.
I can't hear you. So yes, otherwise on the chat, and I'll be clear that I can proceed. Because that is a very basic concept that we must first have the diagnosis. So the first step is the triple test in all situations. So most of the time we end up with patients who are left halfway based on imaging report. So whether if he's given BIRADS 2 or 3, we don't do the biopsy. So those are all incomplete. We know that for all best complaints, it must have the triple test, which includes imaging is just one of the inputs. Patient must have a core cut biopsy to reconfirm whatever is suspected. Only if it is clear cut, no lesion is seen, or 100% benign lesion is seen, in those situations we can observe. But in all other situations, wherever there is even a slight suspicion of malignancy, even in fibroadenomas, which are totally benign, we need a core cut biopsy to look for any possibility of malignancy, to know if there is any possibility of cystosarcoma phyllodes, because eventually in the initial stages, both may look the same. So remember that it's nothing short of triple test will get us past the risk of leaving our patients to be diagnosed in stage 3 and 4, which is our main struggle these days. That we need to start diagnosing our cases early, and therefore more meticulous attention to following all the steps which are advised. So triple test is a must always. Okay, don't stop at just the mammogram. Okay, so now once we have a, TNM staging, that it's early breast cancer T1, T2, N0, N1, so it will fall in one of these stage groups. So remember, rather than stage, remember the TNM category, which is easy to explain, easy to reproduce, and easy to understand to whomever we are talking. So if we say T1, T2, N0, N1, you don't have to explain anything more. We know which types of tumors will fit into that group. And for these tumors, we call them early breast cancer. The correct approach is surgery, and surgical approach is divided on based on what we do for the breast and what we do for the axilla. So the Operative treatment of early breast cancer is subdivided into treatment for the breast and treatment for the axilla. So, treatment for the breast may be either a lumpectomy or a mastectomy, depending on the patient's choice. All the options are explained to the patient, and patient chooses what is to be done. So, patient may choose lumpectomy and whole breast irradiation, or patient may choose mastectomy. So, this is left to the patient's choice. Then what is to be done for the axilla? For the axilla is based on the clinical staging of the axilla. So if axillary nodes are palpable and FNAC is positive, then it is categorized as a clinically positive axilla. If the nodes are seen on ultrasound or palpable but FNAC is negative, it is classified as a clinically negative axilla. If no nodes are seen, or if nodes are seen or nodes are palpable and FNAC is negative, it is classed as a clinically negative axilla. Clear? So treatment, surgical treatment is divided based on treatment for the breast and treatment for the axilla. For the breast, the choice lies with the patient whether she wants a lumpectomy and whole breast irradiation or patient wants mastectomy. For the axilla, treatment is based on whether nodes are palpable or seen on imaging, and if they are positive, clinically positive axilla. If the nodes are palpable, not palpable, not seen, and even if palpable, FNAC is negative, clinically negative axilla. Now, for the clinically positive axilla, always an axillary dissection will be done. So if it's a positive, clinically positive axilla, always an axillary dissection level 1, level 2 will be done. If it's a clinically negative axilla, that is the axillary nodes are not seen, or if seen or imaged, FNAC is negative, then we will go ahead with the sentinel lymph node biopsy. Then based on sentinel lymph node biopsy, if less than two nodes are positive and patient is going for a breast conserving treatment, that is lumpectomy treatment, going to receive radiotherapy, then no further action. But less than two nodes positive, that is one or two nodes are positive, patient is going for mastectomy, we will complete the axillary clearance. If more than two nodes are positive, then always we will do an axillary clearance. So the first 3 to 4 nodes are removed in sentinel node biopsy, sent for frozen section, and by the time that lumpectomy or mastectomy is completed, report comes. If less than two nodes are positive, patient is going for lumpectomy and radiotherapy, no further action. If less than two nodes are positive, but patient has already had her mastectomy done, we will complete and do the axillary dissection. And in case more than two nodes are positive, then in all cases we will do the axillary dissection. So that completes our treatment for early breast cancer. And after the histopathology report comes, then we decide regarding adjuvant therapy for that patient, which may be additional radiotherapy, chemotherapy, and hormone therapy, and added Herceptin in case it is needed. So after the operation is completed, whatever is the operation, lumpectomy or mastectomy, the final histopathology decides what adjuvant treatment patient should get. The adjuvant chemotherapy alone, chemotherapy plus hormone therapy, or chemotherapy, hormone therapy once that chemotherapy is over, to get radiotherapy or not. So which cases get radiotherapy? All cases which are treated with lumpectomy treatment will get radiotherapy. In mastectomy group also they will get radiotherapy if any of the nodes is positive. So if here, if more than two nodes are positive or less than two nodes are positive, and patient has had mastectomy, then patient will still get radiotherapy. Then in case the tumor was T3 or T4, means not an early breast cancer, then also patient will get radiotherapy. And in case margin is positive, patient will get radiotherapy. So this sometimes on final histopathology, the tumor characteristics are revised, and what was thought to be 5 centimeters is actually more than 5 centimeters to get revised to T3, and patient will get radiotherapy. Then coming to locally advanced breast cancer. So in locally advanced breast cancer also there is some confusion, so we should remove that confusion in our mind. So locally advanced breast cancer is T3, T4 tumors or N2, N3 tumors, but no metastasis. So only locally the disease has advanced. So if disease has advanced locally, it makes common sense to understand that the chances of metastasis are higher. So, whenever the chances of metastasis are higher, this plan of treatment, neoadjuvant chemotherapy, that becomes the better option rather than going for surgery first and leaving those metastasis alone, and subsequently because it is an advanced cancer there will be more likelihood of wound complications, so your chemotherapy will keep getting delayed till the wound settles down. So, in all locally advanced breast cancer, though this option exists to operate immediately, but the correct treatment is always this neoadjuvant chemotherapy. That we first, in locally advanced breast cancer, we start with neoadjuvant chemotherapy and we see the response, tumor will become small, and we can offer the same options which we had offered here, that we can offer lumpectomy, we can offer mastectomy, and we can do the axillary clearance. And since it is locally advanced, these patients will all come up for radiotherapy. So these patients will all come up for radiotherapy. Then coming to the last category for breast cancer, that is metastatic breast cancer. So now in metastatic breast cancer, the treatment is divided in two groups, that is patients who have got a visceral crisis and those who don't have a visceral crisis. So what do we understand by visceral crisis? That is the metastasis is so much that it is causing a risk to life. So if the pulmonary metastases are many in number, liver metastasis many in number, or CNS metastases are about to kill the patient, then we will start with chemotherapy first. So visceral crisis is the threat to life due to the metastasis. So here the treatment is chemotherapy first. But in case there is metastatic disease and no threat to life, that is no immediate threat to life, that one nodule in the lung, one nodule in the bone, or one nodule in the liver, then the treatment is based on the ERPR report. So if ERPR is positive, then we treat that patient with hormone therapy. If ERPR is negative, then we treat that patient with chemotherapy. Standard, just keep it like that, and the answer is very, very clear. ERPR positive, endocrine therapy. ERPR negative, chemotherapy. So the rest of the segregations, don't confuse your mind with it at the moment. So consider only visceral crisis, no visceral crisis. If visceral crisis, chemotherapy. No visceral crisis or no immediate threat to life, treatment guided by the ERPR report. If ERPR is positive, hormone therapy. If ERPR is negative, chemotherapy. Now coming to the, I think, last segment before we stop for today, and that is hernia. Now in hernia, you know the standard hernia is a protrusion of a viscus or a part of viscus through a opening in the cavity which normally contains it. Now out of this, there are so many situations from where this hernia can come: epigastric, paraumbilical, umbilical, spigelian, inguinal, femoral, obturator, and at the back, superior lumbar, inferior lumbar, gluteal, and sciatic. Now, when we are assessing our patients, so among the uh, first things which we must say when we have examined our patient is that the patient was examined in the standing and supine position. Now, the advantage is that it automatically clears out the smaller hernias which may not be apparent when the patient is lying down. So when you make that person stand and cough, then you are immediately picking up even the smaller hernias. And the next important thing is this Carnets of audible sign, which we use mainly for abdominal pain, but can also be used to distinguish whether the mass is belonging to the parietes like a hernia or a sebaceous cyst or a lipoma in the abdominal wall, which will all become prominent when either the legs are lifted up or the patient is asked to lift the shoulders of the bed. So usually we try to distinguish for abdominal pain, which may be from the parietes, like a rectus sheath hematoma, or whether it's due to appendicitis or cholecystitis, where once you lift the legs up, the pain from appendicitis or cholecystitis that becomes less, whereas if it is due to a rectus sheath hematoma, that will become more. But the same thing we can use to differentiate between swellings which are in the parietes and swelling which in the intra-abdominal cavity. Then once we examine the patient, we will be describing like a lump anywhere, position, extent, shape, size, surface, edge. So all that we will be describing. So any hernia, that is any protrusion of a viscous, that is it is reducible and has a cough impulse and is close to an incision, will be called an incisional hernia. If the incision is over a inguinal hernia repair, then it will be called a recurrent hernia. There we don't use the term incisional hernia. But in all other places, when the hernia is close to an incision, we will call it an incisional hernia. When the incision is close to the inguinal hernia repair, we will call it a recurrent hernia. So the hernia, we will be describing the shape, the pyriform shape, the globular shape for a direct hernia, and the location of the bulge. If it is lateral and inferior to the pubic tubercle, it's a femoral hernia. Whereas when it is medial and superior to the pubic tubercle, it may be a direct or an indirect hernia. Then we check the color of the skin over the hernia. If it is bluish, discolored, then it may point to strangulation inside it. Then we must know how to do these three tests for any inguinal hernia: the deep ring occlusion test, the invagination test, and the Siemens test. Now, there is a lot of confusion regarding the location of the deep ring. So, I am advising everyone to go back and check from Gray's Anatomy the position of the deep ring, which is the mid-inguinal point, midpoint of the line joining the anterior superior iliac spine to pubic symphysis. So all your books are very clear except Bailey and Love is not clear. So I'm very sorry, but can't be helped. So in that copy and paste method of producing new books, some small errors from older texts keep getting carried on. But all your current clinical examination books are all clear that the deep ring lies at the mid-inguinal point, which is the midpoint of the line joining the anterior superior iliac spine to the pubic symphysis. This is slightly more medial than the midpoint of the inguinal ligament. And that is why sometimes there were errors in the deep ring occlusion test, which have been removed once we take this correct position of the deep ring, that is the mid-inguinal point or the midpoint of the line joining the ASIS to the pubic symphysis, and so that we can press it with a single finger, and in case the hernia appears, it is a direct hernia. In case this deep ring occlusion prevents it from coming out, then it's an indirect hernia. But this test is only possible in reducible hernias. If the hernia only reduces partly, it cannot be called a reducible hernia. A reducible hernia should go back completely into the abdomen. So that is again a very important distinction we must maintain. If it only reduces partly in volume, this test cannot be done. So there is no category called a partly reducible hernia. So you can say that some part of it goes down, but some part remains outside. It is an irreducible hernia. Your final diagnosis must remain irreducible if the entire content cannot be reduced. Then coming to the invagination test. So of course, finding the correct image becomes very difficult at times. The hand has to be turned so that the pulp is facing the abdominal cavity. So while introducing it, your finger can be in any direction. But when you are palpating and looking for the impulse, the pulp must face the abdominal cavity. And if the impact hits the pulp, then it is a direct hernia. If it hits the tip, then it's an indirect hernia. So this is the deep ring occlusion, this is the invagination test. This is the Siemens test, in which the index finger is, after reducing the hernia. Again, this test can only be done after the hernia has been reduced completely, and if when the person coughs, impulse is felt on the index finger, an indirect hernia, middle finger, a direct hernia, on the ring finger, a femoral hernia. Then you come to some special types of hernia, a sliding hernia, where the one of the retroperitoneal structure slides down along with the hernial sac. So it is outside the hernial sac, but it is coming down along with the hernial sac. So that is called a sliding hernia. Then you have the Madel's hernia, looks like a W or an M, where one loop which inside the abdomen and two loops are outside the abdomen, and this is the usual. The internal loop is the one which is most likely to get obstructed and strangulated. Then you have Littrey's hernia, which is the where hernia contains the Meckel's diverticulum. Then you have Ameyer's hernia. A stands for appendix. So in Ameyer's hernia, one of the contents is the appendix. This is the cecum, that's the appendix. In Richter's hernia, only part of the wall of the intestine is involved. So usually we see it in femoral hernia, and part of the gut has come out and the lumen remains intact. So here the patient can have strangulation but no obstruction. So it is because of this unique feature, it sometimes crops up as an MCQ. So which is hernia where strangulation is possible without obstruction. Most of the time, obstruction will accompany the strangulation. Then you have the Spigelian hernia, where the hernia comes out through the Spigelian fascia and the bowel loops are lying within the walls of the abdominal cavity. Then we mentioned how to do the two operations. So again, this is a straight copy from Bailey and Love. So how Bassini's herniorrhaphy is done and how the Liechtenstein's hernioplasty is done. The initial steps are the same, that the hernial sac is identified, ligated, tied off, and then in Bassini's herniorrhaphy, sutures are placed between conjoint tendon and inguinal ligament. In the Liechtenstein hernioplasty, a mesh is placed to cover the area where the defect was. So we'll close today. I think we've had a long session. Thank you all for being here. And if there are any questions, I will still feel free to ask them. Already, many questions have come from the MCQs which were shared. Now, one more last one. Location of stoma. Yeah. I'll just go back to that and then we'll end. Yeah. So when we are creating a stoma, when you are looking at a stoma anywhere, so when you find a stoma in the in the left lower quadrant. So in the left lower quadrant, what is the intestine lying behind? The commonest intestine we see is the sigmoid colon. And so that sigmoid colon can be brought up. It has got a mesentery. Now, other parts of the intestine cannot be so easily brought out. So that is why that is the common location for a colostomy, which may be a loop colostomy or an end colostomy. Similarly, the part of the colon, if you're getting fecal contents, it's a colostomy, and the part of the colon which can be easily brought out next is the transverse colon because it has got the transverse mesocolon. These two, ascending and descending colon, they are stuck to the retroperitoneum and cannot be easily brought out. If we need to bring them out, we will have to dissect them off the posterior abdominal wall. So usually if we find a colostomy here, it is going to be a transverse colostomy. So a stoma in the left lower quadrant is likely to be a colostomy. Stoma in the right upper quadrant is likely to be a colostomy. Now here the cecum can't be brought out. So if you find a stoma here, the only other thing which is lying with the long mesentery here is the terminal ileum. So the loop ileostomies are usually created here. Is that clear? Anyway, so because it is raining, at least I kept you all indoors, safe from the rain. Parents will be very happy. Okay. Thank you. Thank you all for being here. It was a pleasure. And uh somebody asked, should we reduce the hernia if patient doesn't know how to reduce it? Usually, I mean, it's a very rare situation that patient won't know. Most of the time, patients are more experienced than us. So you will be surprised when doctors fail, patients succeed. So it's normally the other way around because they have seen that hernia from the beginning and they have seen the track it takes and how it comes out, and they have been reducing it over this period. So nobody likes to seek a lump all the time. So we, when lying down, going to sleep, they would always be, even if it is not going back on its own, they would have practiced reducing it. So if the hernia is lying outside, of course, first we should try to reduce it, even if patient does not volunteer, because just for the safety of time, that we don't waste too much time in talking and describing things to him. So if the hernia can be reduced easily by you, well and good. If you fail, you can ask him to help you reduce that hernia. Of course, many times when hernias get complicated, they may be reduced only when the patient is under anesthesia, but that is not the topic of discussion. So during clinical examination, we must always try and reduce it ourselves first, so that we can do all those tests which we talked about, the deep ring occlusion test, the invagination test, and the Zeeman test, all require the hernia to be reduced. Which is this week 3 CA. Let me see what is so special about week 3 CA group A. This is year 4 or year 5? Hello? Who asked this? Group A is what, year 4, year 5? Anyway, I'll check both why it's got held up. Because normally I put an automatic feedback, so if it's corrected, it should reach you. I'll just check what's the hold up. Year 5, I'll check that. Oh yeah, 1 year 5 is held up for some reason. Yes, yes. I'll do that today. Okay. What else is there? Adjuvant chemotherapy for early breast cancer. Where are we? Yeah. So, what is the confusion here? Adjuvant therapy. Adjuvant means added on. New adjuvants mean given before surgery. So, in early breast cancer, we will talk only of adjuvant. This new adjuvant which is coming up are special cases which, when we have time later, we will discuss. For the present, ignore this part. Focus only on this, that early breast cancer will have surgery for breast, and surgery for the axilla. Surgery for the axilla in case it is clinically positive. In case the FNAC is negative, it is classed as the clinically negative axilla, and it will go for sentinel node biopsy. And after sentinel node biopsy, more than two nodes positive will get axillary clearance. Less than two nodes will get divided based on lumpectomy treatment or mastectomy treatment. Less than two nodes getting mastectomy will also get axillary clearance. Less than two nodes getting lumpectomy will get adjuvant radiotherapy. So they will fall in this group. So clear, that sorts the surgery. Now once the major surgery is done, whether it's lumpectomy or mastectomy, the tissue will be evaluated by the pathologist. Then, based on the characteristics, the final pathology report, the adjuvant therapy will be decided. So, if the tumor is larger, T2, T3, they all come for chemotherapy. So patient will get adjuvant chemotherapy. Now we've also done the molecular study on the breast cancer, and in case it is HER2 negative, then patient will get Herceptin. Or if it is triple negative, then there is no need for hormonal therapy. But if it is hormone positive, then we add adjuvant endocrine. So, final histopathology will help us decide chemotherapy plus minus Herceptin plus minus hormone therapy. So you leave that based on, so each of those are based on the final histopathology report. So final histopathology report, if it is showing HER2 positivity, Herceptin gets added. If it shows ERPR positive, hormone therapy gets added. And in case it is T2 or T3, the chemotherapy is added. If it is very early breast cancer, patient is elderly, then patient may not require any other therapy other than hormone therapy. So those are the separate categories. So you leave all of them together, that based on the final histopathology report, adjuvant therapy is decided, which may be chemotherapy plus minus anti-HER2 or Herceptin or plus minus hormone therapy. Now, additionally, radiotherapy is given after completion of chemotherapy. In case it is a lumpectomy treatment, all patients get radiotherapy. Then, in case in mastectomy patients, in case that lymph node, any lymph node is positive, patients get radiotherapy. In case the tumor is restaged to T3 or T4, then patients get radiotherapy. And in case any margin is positive, patients get radiotherapy. Are we clear?
Yes, doctor.
Okay, thank you all very much. And please go through these slides. And in case you have any other questions, already I've received a few, feel free to ask. It's only with this dialogue we will sort out all gray areas, that where some teaching does not match and where we are confused. Okay. Okay, all the best. Thank you all very much.
Thank you, doctor.
Thank you, ma'am.
Okay, bye bye. Final check regarding questions. Any? Great. So for slides, those who have not received, please let me have a complete list of emails. I'll send the slides to them.